to be at your annual conference of Arabic Association for Study of Diabetes, and I would like to express my gratitude to Professor Ina Shautot for inviting me here, and to the organizing committee. It's always my pleasure to be in Egypt, in your beautiful country. This time I have time even to visit few famous places, and please I am expressing my gratitude once again to Professor Shautot and all organizing committee for inviting me here. And Professor Shautot was in Croatia several times, and it's our pleasure to have people from Egypt in Croatia, and because the most important thing is to exchange our knowledge. Today I will speak briefly about inflammation in type 2 diabetes. It's a huge topic. Unfortunately, we will not have time to tackle all of them, but we know that diabetes causes a mild of inflammation processes in the body, and chronic hyperglycemia related to diabetes is associated with end organ complications, not just kidney, not just cardiovascular system, but also nerves, heart failure, chronic kidney failure, and many other chronic diseases. Landmark study to correlate inflammation with diabetes was a study published in 1993, and that study emphasized the role of TNF-alpha in obesity, in insulin resistance, and diabetes. On the other hand, we know today that TNF-alpha is very important mediator of inflammation. TNF-alpha has important role in catabolic effect on fat acids, and its direct role in obesity related or obesity linked insulin resistance. So TNF-alpha is elevated locally and systematically, and can increase neutralization of TNF-alpha, can cause a significant increase in uptake of glucose in peripheral tissues to insulin. So it seems that TNF-alpha has important role in the glucose tolerance, and also the insulin resistance or insulin sensitivity. On the other hand, it plays an important role in obesity, and particularly insulin resistance and diabetes. And it's a very busy slide. I will not go into details because of a matter of time, but in type 2 diabetes and obesity, there are many elevated levels of markers and mediators of inflammation. You can see it here. It's not just about acute phase reactants. It's not just about the CRP, but also interleukin, IL-6, and also fibrinogen, white cells, and many others. And you can see that chronic activation of pro-inflammatory pathways in target cells of insulin actions can contribute to obesity, insulin resistance, and even to development of type 2 diabetes. So, and also diabetes-related metabolic disorders on the other hand. So we have a circle between diabetes, obesity, metabolic syndrome, and pro-inflammatory state, and many pro-inflammatory and disbalance of pro-inflammatory and anti-inflammatory mediators. On the other side, when we talk about biomarkers of inflammation or inflammatory biomarkers, we recognized those who induce inflammations, and the most popular in everyday clinical practice is, of course, CRP. We can see it in people with type 2 diabetes. Many people who are just obese or have type 2 diabetes, they have elevated CRP levels in serum. And also, CRP is produced by liver and, of course, fat cells. So that's the reason why in type 2 diabetes and obesity and metabolic syndrome, we do have elevated CRP levels. On the other hand, production in liver is stimulated by TNF-alpha and interleukin-6. So IL-6 and TNF-alpha also can stimulate liver to produce CRP. and many other, I will not go into details of intracellular adhesion molecule 1 and many others. On the other side, TNF-alpha produced by various cells, but mostly from macrophage and adipocytes origin. And it's involved in obesity and insulin resistance, as I already mentioned. On the other side, we have those who are biomarkers who reduce inflammation, and its adiponectin is one of the most famous in everyday clinical practice, and mainly produced by adipose tissue. And we know that anti-inflammatory effects. His anti-inflammatory effects go into inhibition of macrophage of ability to activate themselves, and also not just themselves, but also other cells which can cause inflammation. And also low levels of adiponectin was observed in patients with metabolic syndrome, but also with people with obesity and type 2 diabetes. So we are right now very aware, we are aware of the importance of weight loss and lifestyle changes due to adipose tissue and due to obesity. But the role of adipose tissue is much more than just to say, oh, it's an aesthetic problem. Because, as you know, the adipose tissue is the main organ of the main endocrine organ, which produces many different adipokines and cytokines, especially those who are causing inflammations. So those adipokines can be pro-inflammatory and anti-inflammatory. Metabolic syndrome, hypertension, and dyslipidemia are positively associated with the concentration of inflammatory markers. And you know that these markers are also predictive, that they can predict insulin resistance in people with type 2 diabetes and incidence of type 2 diabetes and also incidence of cardiovascular disease. So that's the reason why all scientists are trying to find the novel biomarkers, early biomarkers of which can predict the development of type 2 diabetes, and also early development of chronic complications, including cardiovascular complications, which are very important nowadays. One of them are also glycans. As you know, glycans are right now very modern, or messenger RNA, and many others. But subacute chronic inflammation, it's common in obesity and metabolic syndrome, and you can see it here in this slide, activation of at least two major inflammatory pathways. One is J and K, and another one is transcription factor NF-kappa B. So inflammatory state further amplified by adipokines, which I already mentioned, from adipose tissue, and they will stimulate the inflammatory response in obese people and promote obesity-induced metabolic and cardiovascular disease. As I already mentioned, the role of adipose tissue is not just an aesthetic problem, but the role of adipose tissue is much more important. And in comparison to brown tissue, white adipose tissue produces lots of cytokines, which are already mentioned, and other chemokines, like TNF-alpha, which has important role in glucose uptake, as you remember, and insulin sensitivity, but also IL-1, IL-6, IL-10, leptin, adiponectin, resistin, and many others. So also macrophage, they have important role on inflammation, and macrophage and other immune cells infiltrate adipose tissue, triggering local and systemic chronic low-grade inflammation, and it could be a pathophysiological link between obesity, metabolic syndrome, insulin resistance, and type 2 diabetes, maybe even with cardiovascular disease as well. So we know that adipose tissue inflammation is right now something which is pretty common and normal, and we do have a low-grade inflammation. And phenotype switching of macrophage, predominantly anti-inflammatory M2 type, to pro-inflammatory M1 type, plays a crucial role in the initiation of islet inflammation. So it's not just the importance of macrophage in obesity and also in the glucose level, but also in islet inflammation, but also it can have it can play an important role also in other tissue like liver, neural system, and skeletal muscles. Pathophysiologically behind obesity induced insulin resistance is a huge numerous processes, and you can see it here. Western prudent diet, which is typically with the high fat diet intake, in that case adipocytes became hypertrophic and also infiltrated also with NK cells, which will promote the expression of pro-inflammatory cytokines and secretion of pro-inflammatory cytokines. It will cause production of another pro-inflammatory cytokines, especially activation of macrophage, polarization and activation, and that can cause insulin resistance. And it's a circle, vicious circle, which can cause not just diabetes, but also diabetes-related metabolic complications. On the other side, we mentioned the influence of those pro-inflammatory cytokines in the term of glucoregulation, but also we have to mention the role of inflammation in beta cell or islet inflammation. So the role of pancreatic beta cell failure is already pretty well established, and previously before that beta cell died due to apoptosis and due to insulinitis. Today we know that it's only partially true. It's not just about apoptosis. We do have the process of dedifferentiation of alpha cell and putting beta cell on a way to become non-beta cell, which produce different hormones, including glucagon, somatostatin, and many others. And in the insulinitis, it seems that macrophage plays a key role in islet inflammation in type 2 diabetes, but also other types, inflammasome and IL-1 beta signaling is important to cause beta cell dysfunction, maybe not just failure in beta cell loss, but also beta cell dedifferentiation. On the other side, we have many different explanations how hyperglycemia can cause beta cell failure, and one of them are the hyperglycemia may induce the production of IL-beta by stimulated pro-apoptotic receptor for free fatty acids, and you know that free fatty acids and acute exposure of beta cells to beta cell, free fatty acids to beta cell can cause glucose secretion. But on the other side, free fatty acids can also produce and secrete IL-beta and IL-beta pro-inflammatory cytokines in pancreatic islets. So that's the reason why free fatty acids and chronic exposure to high level of free fatty acids, we know that, and we call that lipotoxicity, can lead to further lipotoxicity and beta cell failure. I will not go into details, but we have to mention the role of macrobiota. And you know that microbiota is very important because it's implicated in the pathogenesis of numerous diseases, including metabolic diseases like diabetes and obesity-related metabolic disorders. But due to Western prudent diet and high fat and carbohydrate intake and lower intake of fibers, that can cause also and increase the risk of diabetes and diabetes related complications, and also inflammation. So why? because fibers, as you know, fibers cannot be digested by humans in our digestive system, but they are fermented by gut macrobiota. And the final product is short-chain fatty acids, which are generated as metabolites, and those metabolites can act as anti-inflammatory cytokines and can cause production of anti-inflammatory cytokines. In opposite way, as free fatty acids played an important role in diabetes, but on the other side, we noticed that several studies reported that numerous bacteria were significantly lower in type 2 diabetes, and also they can, due to lower and different ways of gut microbiota, can have huge implications on general health on people with diabetes. But in people with diabetes, we notice that these biota can cause different things, and these biosis can cause lower production of short-chain fatty acids, but also lower production or to reduce reduction of GLP-1 production, and also low-grade inflammation in body of people who are obese and people who have diabetes. Roles of macrobiota is that they modulate inflammations, but also affect gut permeability, affects glucose and lipid metabolism, as I already mentioned, affects insulin sensitivity and glucose intake, but also affects overall energy homeostasis. So, ladies and gentlemen, you would agree with me that some microbiota are very important in obese people and overall people with type 2 diabetes. On the other side, we have to mention that some microbes can affect the host physiology by increasing other beneficial macrobiota. So from that perspective, they can have beneficial effect on its host. And pathophysiology of gut microbiota on type 2 diabetes, we have to mention just the modulation of inflammation, which I already mentioned throughout the promotion of anti-inflammatory cytokines production, but also they will decrease gut permeability, what is very important. As we know, the gut permeability in obese people and people with dysbiosis is pretty high. On the other side, have direct and indirect effect on glucose metabolism, but also on fatty acid oxidation, synthesis, and energy expenditure. I mentioned here several of them, which are the most important microbes in microbiota in healthy people, but also in people with type 2 diabetes. So we can speak about the inflammation in type 2 diabetes, but we have to ask ourselves what about treatment options and targeting inflammation to delay development of type 2 diabetes and its complications. And some current anti-hyperglycemic treatment can have effect on decreasing inflammation. And as you can see, of course, weight loss and lifestyle intervention can change a lot of things, including our microbiota, and can reduce CRP level and IL-6 concentration, what was published in many studies. But also, it seems that insulin can reduce inflammation, decreasing NF-kappa beta activity in peripheral blood mononuclear cells, but not just insulin, but glitazones, metformin, DPP-4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonists also shown to have anti-inflammatory effect and beneficial effect on reduction of inflammation. So for the example, you can see it here, and SGLT2 inhibitors show that they can reduce glucotoxicity and lipotoxicity, can improve the beta cell function, but also it seems that they can reduce oxidative stress, fibrosis, and sympathetic overdrive, stimulating anti-inflammatory macrophage and also anti-inflammatory cytokines like IL-10. also in the heart, but also in the kidney. They will reduce TNF-alpha and IL-6, fibrosis, and apoptosis. We know about the statins. Statins have beneficial effect on the plaque stabilization, but due to conflicting effects on glycemic control, it's still controversial. But we know that all people with diabetes should have statins. Statin therapy, salicylates, they do have anti-inflammatory effect, but also with lots of side effects. That's the reason why new guidelines say that only in secondary prevention, but not in primary prevention for sure, and even for secondary prevention is discutable. Biological agents as anti-inflammatory therapy in type 2 diabetes, there are many of treatment possibilities how to decrease inflammation in type 2 diabetes, and the most prominent and right now the most investigated approach are TNF-alpha antagonists. Several studies did not demonstrate adequate results, and you know that TNF-alpha agonists are used to treat many inflammatory conditions, especially rheumatological and other autoimmune disease. On the other side, IL-1 beta antagonist, but it seems that in a huge study, CANTO study, did not reduce the incidence of diabetes in patients with prior myocardial infarction and high CRP level. There are also several other treatment options, but we learned a lot from COVID-19 and diabetes, because we learned how inflammation and inflammatory response is important in type 2 diabetes, and we learned that diabetes is the most common and the most important risk factor for severe cases of COVID-19 or SARS-CoV-2 infection. I will not go into details, but when we look about COVID-19 and diabetes and the severe form of disease, we learned that cytokine storm can be responsible for the multi-organ failure and consequently death and very severe form of disease. Unfortunately, we don't have enough time because our time is already finished, but one of the last slides, I would briefly would like to express why, emphasize why the inflammation is important in type 2 diabetes. We learned that from COVID. It's not just about increased ACE2 expression, but also increased furin, impaired T cell function, increased IL-6, and many different things and pathophysiological models were found in COVID-19 during this COVID era. So, in summary, you would agree with me that diabetes and hyperglycemia causes a mild of inflammatory process in the body. Obesity-related adipose tissue leads to increased insulin resistance and chronic inflammations. Fat tissue is not just a matter of aesthetic, but fat tissue is a very important endocrine organ, and which plays important role because of producing inflammatory, pro-inflammatory cytokines. Microbiota have an important role in glucoregulation, but also in expression of genes and expression and production of anti-inflammatory effects of good microbiota. Current anti-hyperglycemic drugs already show the beneficial effect on reducing inflammation, but there are still many things to do in research how to reduce the inflammation in type 2 diabetes, not just because of avoiding chronic complications, but also to improve glycemic control and also to improve, to lower the infection and also inflammation in type 2 diabetes. And people with diabetes have a higher risk of severe COVID, SARS-CoV-2 infection, but not just during COVID infection. You still remember also other SARS and other infections, but also pneumonia and caused by pneumococcus and also influenza. So people with diabetes, they do have impaired immune response, and they already have low-grade local and systemic inflammation, local in fat tissue, but also local in pancreatic beta cell or in pancreatic islets, but also all over the body. So we have to learn a lot about inflammation and how to decrease inflammation, because like George always said, helping others is good, but teaching them to help themselves, it's even better. Thank you very much.
Thank you very much, dear Dario. Because lack of time, we have just